Hello, everyone, and welcome to the NCCN Best Practices webinar series about creative strategies developed during the COVID-19 pandemic that will impact the future of cancer care. My name is Jessica Sigelski, and I'm the Director of Process and Program Management at NCCN. In this second session of the series, we will be discussing policy and reimbursement considerations for telemedicine. NCCN would like to thank these organizations for supporting this webinar series. We greatly appreciate their contributions, and without them, this program would not be possible. I would now like to introduce our speakers for today. Our first speaker will be Dr. Jennie Crews from Seattle Cancer Care Alliance. Dr. Crews is Medical Director for the Seattle Cancer Care Alliance Network, Administrative and Medical Director for SCCA Community Sites, and a Clinical Associate Professor of Medicine at the University of Washington with a clinical focus in survivorship. Additionally, Dr. Crews was President of the Association of Community Cancer Centers from 2016 to 2017 and is Editor-in-Chief of ACCC's Oncology Issues. She has co-chaired the ASCO Practice Guidelines Implementation Network, and she is the current president of the Washington State Medical Oncology Society. Our second speaker today will be Dr. Tim Kubal from Moffitt Cancer Center. Dr. Kubal's research and clinical interests are in myeloid malignancies with a particular focus in acute leukemia. In addition to his clinical efforts, Dr. Kubal serves as Senior Medical Director of the Moffitt Outpatient Center at AbbVie Wesley Chapel. He is also Director of Clinical Operations for the Department of Malignant Hematology, Medical Director of Infusion Services, and Medical Director of Process Excellence. Additionally, he is an Associate Member in the Department of Malignant Hematology. Thank you, Dr. Crews and Dr. Kubal, for joining us today. Before we get started, I want to remind everyone that if you have any questions during today's presentation, please feel free to submit your questions through the Q&A box located on your screen. We should have time to address questions towards the end of the webinar. And now I will hand it over to Dr. Crews for our first presentation.
Hello, and thank you, Jessica, and welcome everyone to this webinar on telehealth. I'm happy to share the portion on regulatory changes in telehealth in response to COVID-19. What I'd like to do in our time together is review the CMS telehealth regulatory changes that did occur as a result of the response to COVID-19, and also look at the impact of these changes on workflows and billing, to understand state licensure changes in response to COVID, and then share a little bit about what we've done at Seattle Cancer Care Alliance with regard to telehealth, and then ask you to imagine a longer-term role for telehealth and oncology and what that might require. I have one disclosure, and that is that I am not a lawyer. I'm talking about regulatory changes, and there certainly are a lot of legal and compliance consequences of those changes, so I would certainly encourage you to contact your legal and compliance teams at your institution before acting on any information. It's a good place to start with just some definitions because these play into some of the regulatory topics that we're going to discuss. So when we say telehealth, we mean using both video and audio as opposed to telephonic consultation, which is just the audio. Originating site is where a patient is located at the time service is rendered, whereas a distant site is where the provider is located during that time. And when thinking about new patients versus established patients in telehealth, the definitions really are the same as when we see them in in-person visits. Now, a lot of our colleagues in other areas of medicine, like primary care, psychiatry, cardiology, have had a more robust experience with telehealth prior to COVID. I think oncology, with the exception of a few pockets around the country, has not really embraced this care modality to the same extent as some of our other specialty services. And there are a lot of reasons for that. There have been some significant historic barriers to adoption of telehealth. Certainly, there have been regulatory issues both at the state and federal level. There have been reimbursement issues that sometimes tie into those regulatory issues and challenges in demonstrating a return on investment. There are institutional potential barriers around credentialing, who provides oversight, buy-in from providers or from patients. Logistical and operational barriers include the changes that have to be made in scheduling and documenting patient flow through the clinic, since patients are not physically present. And then certainly there are platform changes as well that can occur. Now, for issues around CMS and telehealth, one of the major concerns prior to COVID and the response to COVID has been who is considered an eligible provider. So CMS had pretty stiff restrictions around who could conduct telehealth visits. These include MDs, APPs, and then a smattering of other supportive services. They also had pretty strict restrictions around geography. So patients had to be located in a health provider shortage area or in a rural area in a county outside of a metropolitan service area. And CMS did not recognize home as an acceptable originating site. They did provide a nice tool. If you went on the HRSA.gov site, you could plug in an address of a location and determine whether or not that was going to be recognized as a site for telehealth to be provided. Other issues prior to COVID included restrictions on the originating site. These were largely hospitals or provider clinics. Some rural health centers and other specialty centers were allowed to be originating sites for telehealth. Billing required modifiers, a telehealth site of service code, and there was lack of payment parity on billing for telehealth and pretty meager facility fee reimbursement. In addition, modalities were initially restricted, but really CMS prior to COVID had started to come around to offering a number of other modalities in service, including the use of virtual check-ins. So new codes had been established that allowed other check-ins, and patient-initiated consultations through portals were recognized and reimbursed, as were interpersonal consultations as well. To get into that modality just a little bit more, here are some of the codes that had been developed and implemented within the past year prior to the COVID response. So the G2012 code was developed for virtual check-in for established patients, but was reimbursed at a pretty low rate of only about $15. There were patient-initiated communications, as I mentioned, through patient portals, as well as the ability to analyze, store, and forward technology. If patients were sending, for example, photographs or images of X-rays, those could be evaluated and charged for, but all of these had pretty low reimbursement rates. There were also significant state-to-state variations in telehealth laws, so the type of telehealth modality allowed was variable, as was the definition of originating site. There were restrictions around what providers were allowed to practice telehealth, and differences in whether new patients or only established patients could be seen. Some states required a business license, and states had a lot of variability in payment parity. There was also a barrier state to state around licensure. Now, to overcome that barrier, the Interstate Medical Licensure Compact was created, but still can create some work to become licensed in multiple states. This is an example here of states that are participating in the compact. To participate in that, you pay a fee, and the fee's around $700, and then you can indicate which states you want to have licensure in. The compact takes care of the paperwork for that, and then you pay additional fees for whichever states you want to have licensure in. So it's really meant to help alleviate repetitive paperwork from state to state. Payment parity also varied, and the details around the definition of parity are important to note because in some states, payment parity meant that telehealth visits were paid if an in-person visit was also paid, but not necessarily at the same rate as an in-person visit. Other states did have more robust payment parity laws that allowed or that it required payment at the same rate as an in-person visit. So then came COVID, and things changed rapidly. They changed rapidly from CMS's standpoint. They changed rapidly from many institutions' standpoint and how we responded to COVID. And with this rapid change, we had to act because standing still is not an option when we had such a momentous event. The federal health regulatory changes related to COVID rolled out in 2 waves. So the first occurred in March with the CMS 1135 waiver. And what this did was allowed patients to be seen at more locations than previously, including recognizing home as an originating site. It also created payment parity between telehealth and in-person visits. It clarified that providers could be at home when conducting these telehealth visits, and it allowed for new or established patients to be seen via telehealth. What it did not do initially was expand the definition of the eligible provider. At the end of April, CMS did issue a second round of regulatory waivers that did allow more eligible providers, and so the definition was expanded to include any professional who could bill Medicare for their services. And an example of that is physical therapy and occupational therapy, and this opened the door to more services being able to be provided via telehealth for patients as a response to the COVID emergency. The other thing that CMS recognized was that not all patients necessarily have access to the video portion of a telehealth visit, and so they recategorized some CPT codes, 99441 through 99443, as telehealth rather than telephone codes. And this allowed increased reimbursement for those codes to enable providers to conduct telephone visits when patients did not have the video capability. The other thing that the second round of waivers did was to extend the definition of outpatient departments to the patient's home, which allowed hospitals to bill for facility fees. Now, the devil is always in the details here, and there are quite a few steps that have to be taken in order to bill a facility fee for a patient at home. You have to have a process in place to flag patients to have been screened for their telehealth capability. You have to submit a letter stating that you want to use facility fee billing for patients at home, and then you have to be able to provide nursing documentation of those visits, as well as establish the addresses of those homes. So it's pretty complicated, but does allow institutions to take advantage of that if they so desire. The other thing that I think is really interesting about this second waiver was how they addressed billing and allowed billing on total time of a telehealth visit, which included both the preparation time prior to the visit, the time during the visit, and then any time spent in care coordination and documentation after the visit, as long as that time was done on the same day as the visit. Some other areas of federal health regulatory changes that were relaxed include Health and Human Services Office of Civil Rights relaxing concern around penalties for HIPAA violations. So if good faith was exercised and yet there was a privacy violation, the Office for Civil Rights said that they would use discretion in whether or not to issue any penalties. This basically meant they would turn the other way as long as good faith was exercised, and this allowed for expansion of the platform for telehealth visits. On the state level, some regulatory changes that did occur in relation to COVID-19 included allowing Medicaid to provide coverage for telehealth services without seeking federal approval. And then many private payers, which are regulated at the state level, did expand their telehealth benefits. Some of them waived cost sharing and co-pays for telehealth visits, and others allowed coverage of telephone visits. Licensure also had been a big barrier, and in response to the COVID emergency, some states did waive the telehealth waive their licensure requirements. This is a really great website from the Federation of State Medical Boards that has an updated list of what states do waive their licensure. You can go to that site, click on that link, and they'll list a summary from each state as in the current environment around what they do require or don't require. Again, I caution you to read the details because some states do a blanket waiver, other states require you to have some registration with that state or expedited licensure within that state. And then some states, in order to waive an in-state licensure requirement, require you to be sponsored by a healthcare entity within that state. I also put up this alert that now some of the states are retiring their emergency declarations, so the waivers may or may not be in effect. So being timely with this information is critical. So what did we do at SCCA in response to telehealth for COVID response? Well, the first thing we did was expedite the telehealth credentialing. So we had always required credentialing as part of our telehealth privileging, but the University of Washington, where our credentialing is done, expedited this, rolled it out to any provider who wanted that. And so many of our APPs and MDs and supportive care providers were able to get instant access to their credentials. We equipped additional space in the clinic for telehealth visits using cameras at desktops or providing laptops available for the providers to use in that space. Prior to COVID, we had been doing some pilots in telehealth, and so we had limited space in our clinic that was designated and had to rapidly make changes to allow more of the clinic space to be telehealth enabled. We also overcame the difficulty when we're registering new patients for telehealth by having them sign all of their waivers and forms by instituting a verbal consent process for them to do that. We created a help desk so that patients who were participating in telehealth could have a source to call if they were experiencing difficulty. And in addition, deployed an expert team to help with our providers who may have been challenged initially with getting through all of the technology for a telehealth visit. We created job aids with help around documentation and billing guidance, and also created an algorithm for our intake department, which is where the referrals come, so that they could determine whether or not referrals from out of state were eligible for a telehealth visit. These are just our statistics from our telehealth experience here. This is from about a week or so ago, but we've had over 6,500 telehealth visits conducted to date. And we peaked at about 38% of our visits at our large South Lake Union campus and 22% of visits in our community practice in about mid-April. That has tapered off a bit as we've begun to bring patients back in for in-person visits, and we're now consistently running around 20% of all patients being telehealth visits. This seems to be fairly consistent with what we're hearing other institutions are doing. In a recent NCCN survey, it seems that many institutions are targeting for 20 to 30% of their visits going forward to be done via telehealth. We also provided some guidance around billing, so there was language around how to bill for total time. This is just an example of what that language looked like. We did ask our providers to bill using GT modifiers because it did help with our coding and billing department identifying those visits as telehealth visits. We gave advice around using telephone and telehealth for both new and established patients. and provided providers with information around CPT codes for billing telephone visits, included those on the EB sheets as well. Documentation guidance we provided included listing how the visit was conducted, where the provider was during that location and where the patient was, including anyone with the patient, and including anyone participating on the provider side, such as residents, nurses, or other staff. This is an example of consent documentation that we recommended. We also gave some guidance around privacy. So we had the ability to roll out a HIPAA-compliant Zoom account for each of our providers, and that's what they used to schedule the visits with their patients. We asked them to use the waiting room feature and later we enabled that feature to be present as a default, which keeps patients from coming into a visit that they're not scheduled for. And then we gave advice around not recording visits. What we're doing now is we're really optimizing all of these efforts. We're trying to create a location for a single source of truth for all providers to go to learn more about how to do telehealth and what the updated regulations are. We also have been expanding locations within our clinics, both in our main campus and in our community program, for telehealth to occur. We're trying to now bring in a little bit more of a nursing presence within telehealth for evaluation at the time of the visit to do med reconciliation and assessment. And we're exploring the possibility of billing for the facility fees for these services. We also are creating a broader telehealth support infrastructure than we had before COVID hit, and looking at ways that we can overcome this rollback in state licensure by identifying providers to get licensed in states where they receive many patients. We've incorporated a telehealth survey within our Press Daily survey that goes out to patients as well. So where do we head from here as a country and as a specialty in our use of telehealth? Well, I think we can safely say that the genie is out of the bottle. And I do think that there are going to be regulatory relaxations that persist even beyond the emergency declaration. I don't think the CMS is going to return completely to the prior state, but I also don't think it's going to maintain all of the relaxation that we have enjoyed since the beginning of March. Likely, telephone reimbursements will go back to what they were pre-COVID, and I think states will likely tighten their licensure requirements to pre-COVID. We're already beginning to see that. However, I think there is strong advocacy to maintain home as an originating site. Just today, there was an announcement made that there is interest from the federal government in doing this, and there's been a group that's been convened as an advocacy group to encourage this to happen. I think payment parity may be in jeopardy, but payment equity may go forward. So equity would mean that telehealth visits would be paid for, but perhaps at a portion of what an in-person visit would be paid for. And then I think also what's likely to happen is that the broadening of eligible providers may be maintained. There's also a need for advocacy around patient access because not all patients do have devices. Interestingly, we were in the process of doing a psychiatry pilot in some of our rural areas where we have network sites. And we did find, though, that the majority of patients in those locations do have access to either a smartphone, a tablet, or a computer. Only 8% of patients said they didn't. But I do know that other areas of the country are more challenged with patients having access, both in rural areas but also in interurban centers. And then we need to make sure that patients have appropriate internet access to conduct telehealth. These are some of the groups that have been involved in that advocacy and have come out with policy statements, who are engaged with lobbyists and with legislators and other bodies, regulatory bodies, to try to advocate for some of these regulations to be relaxed on a permanent state. Here are some resources that you might find helpful. The American Telehealth Association has some fabulous resources, as does the Center for Connected Health Policy. The Center for Connected Health Policy has great state-to-state information as well. CMS, believe it or not, has a pretty good website on telehealth codes and payment. And then the Federation of State Medical Boards is a great resource to look at licensure requirements. Just want to remind everybody, we're still in a state of needing to prevent the spread of COVID. So remember your masks, remember your social distancing. And then I'd just like to thank you for tuning in and being part of this webinar today.
Thank you, Dr. Crews. That was a really comprehensive overview of our regulatory environment that the cancer centers are facing today, and very good insight into what we can expect in the future. I did see a couple questions come in through the Q&A box, so we will try to address those at the end. Members of the audience should feel free to continue to submit your questions, and we will now hear from Dr. Kubal from Moffitt Cancer Center.
Cool, thanks, Jessica. So what I'm going to talk about here is it's important to understand the regulatory and the financial piece of this, but then we've got to also talk about how are we going to position ourselves to these challenges in the future. So we're going to walk through reimbursement, the impact on revenue that we're seeing, and then also challenges and what I would personally advise as next steps. So I'll take you back here, take you back to the halcyon days of February, where there wasn't any COVID. You could fly across the country for no good reason to drink wine with your dad on the left and your brother on the right. Everything seemed fine, right? You were still doing medical visits in your office. Occasionally you would find yourself in a bathtub full of filthy pink balls, touching a phone that probably has COVID on it to your face, with no cares at all in the world. And then when you show back up at home, or in my case, before you leave, this is your Sam's Club cart, right? So I've got like triple the milk you're allowed. I've got cruisers in a size bigger than my son, right? I bought all the tissues, incredible amounts of frozen pizza, the necessary rice and beans, and then kind of a break glass in case of M&Ms down here. I bought all the Clorox wipes, sorry about that. But things changed, right? So big change from sitting in a thing of pink balls to having this be your cart. So what happened, right? What happened? So what happened was COVID. So what I'm going to show you here is this is just the 7-day average recently. I'm sure you guys look at this every day. And what we saw in March in our organization is what a lot of people saw, which was this incredible fear. I remember even when I was flying home in late February, when there were virtually no cases, that we were sterilizing everything on the way back through the lounges and different parts of the airport. And when we came back, my first couple of clinics were 15 to 20 patients in the clinic, and I'd have between 3 and 5 people show up. And people were no-showing and calling and canceling because they were afraid to come in, right? And so then it was weird because we figured out cancer patients still need care, right? It doesn't just go away like a disease shows up, but cancer still kills more people. But people wanted to feel safe, right? So they knew they needed care and they wanted to feel safe, and they said, well, could you bring it to me, right? And what we said to that was, yeah, actually, totally. We could. We never even thought of that, but we could bring it to you. And so this is our data at Moffitt Cancer Center, very similar spike, and I've compared it to the national spike. This is interesting. In January of 2020, we were doing an average of 10 visits a week. When COVID started to really ramp up and we saw cancellations, that jumped quickly with early adopters, and we peaked at 1,600 visits per week. And interestingly, are now leveling off in about the 600 to 700 visit number, which is between 15 and 20% of our visits. So we're seeing very similar things to other organizations. Our peak was massive, very similar to what was seen in Seattle and other organizations. So we said, great, we're going to do these things because patients need it. Are we going to get paid for this, right? So people start to ask those questions. Good news. It's going to be paid for equivalent to an office visit, right? That's fantastic. That had never happened before. Then they tell you they're going to actually pay you for a facility fee. So your nurses can contact people and be talking through medications and things like that. Granted, it's significantly less, but thank you for doing that, right? We appreciated that. And then you say to yourself, well, what about everything else, Tim? What about the other things that were coming in with these patients? So infusion, that would be your first worry. You go there first, right? So I got good news for you on that. Not a significant reduction in our infusion numbers at Moffitt. I would venture that you're seeing something very similar. It's about the same, and it was actually a little higher right in the beginning of COVID. Radiology would be the next place you would go. I would venture here that what you're going to see is a big dip with COVID. What we have found is that never recovers. And so it will recover towards baseline, but when we've closed, for example, for hurricanes or things like that, those scans and visits, they just don't come back. They're moved, right? So what we're looking at is about a 10 to 15% decrease in imaging. So I've told you that reimbursement, isn't bad, right? It's happening for the visit. It's happening for a facility fee. It's happening for infusion. But there's a couple of areas where we have concerns, right? In both the labs and the radiology, there's a real risk for sustained declines in those two spaces. So that's something that we've got to talk about and think about. Because the kicker is everybody loves it. I'll tell you, I've got patients that live within 5 minutes of my organization who did telemedicine because they had other problems. All of them have said that after the COVID is gone, that they still want to do telemedicine. They live 5 minutes away, right? It's just easier for them. I show up on time. They're in, they're out. It's a good product, right? So this is not going to go away. And actually, if you look at our numbers, our patient ratings for these visits are actually higher than the total in-person experience. And so this, I think, will stick, as we said, in that 15 to 20% range for us. It also peaked around the 30+%. We're not sure if that's sustainable, but we think 15 to 20 certainly is. So my advice for you on this first point would be focus on value delivery to the patient, right? No one has ever gone wrong at relentlessly defining value and delivering it. No one will be mad at you if you say, well, I'm delivering value. No one's going to be mad about this, right? Patients think quality is important, but things that are more important are safety and convenience. If you ask a patient if they want to see the best doctor or one across the street, they want to see the one across the street if the best one is 2 hours away. Safety, convenience, and quality in that order. And then interestingly, they don't define better the same way you do, right? I've talked to some doctors in my organization and they say, we're really good, right? We've got better outcomes than other people, right? Objectively, they say we are better. The patient doesn't know that, right? So the patient actually defines better differently. So I would venture an exercise for you here, just so you believe me on that, right? Because a lot of us work in really great institutions. All right, here's two children, okay? Kid on the right, he's my nephew. He is 3 years old. He is fabulous. He's wearing a Florida Gator shirt there. Kid on the left, that's my son. He's 18 months old. He's gigantic. He's wearing a Mickey Mouse shirt. So look at those two shirts, right? And I would ask you, which of those shirts is the best shirt? Right? So, okay, well, you're going to say, okay, well, I could look at the shirts and I could check out the stitching and I could figure out where it was made and I could look at that. Okay, well, fair enough. You might say, well, I'm from Georgia or I'm from Tennessee, right? So I do not like that Gator shirt, or I'm just not a Mickey Mouse fan. So even though I don't know anything about football, I'm liking that Gator shirt. The point I'm making here is that I've asked you to objectively decide which of these shirts are better, and that's not possible for you to do. And there's 200 people or so on this thing, and you all did it differently. You said which shirt is best. You don't know, right? Cancer is a lot more difficult to understand than these two T-shirts. And so it's important for you to remember your patient does not define better the same way you do. Don't expect that a 3% improvement in survival rates at 5 years is going to cause somebody to drive 2 hours back and forth. Think about this the next time somebody is saying to lean only on quality, because that won't get you there by itself. So then how do we adjust, right, for the potential for lost revenue? So I'd tell you there's two options. The first one is you can change. You can change your cost structure. You can change your revenue model. We're going to say it's 15 to 20%. You might have less people. You might have less square footage to heat and cool. You might focus on value-based contracting, right? These are all things you could do. You could change the way you work. You could also grow. You could say, we're going to do a ton of telemedicine. We're going to do more high-quality services to more people that don't live near us. We're going to leverage those 49+ states. We're going to pray this keeps going, and we're going to grow instead of changing. And you're going to take this, you're going to snapshot this, you're going to take this over to your CEO, and you're going to say, we got to decide, should we change or should we grow? And your CEO is going to look at you and going to say, you know what? We should do both, right? I would venture and I would tell you that you're going to have to change and grow to be successful in the new world here, right? You should actually be creating two products, okay? So you often think of the patient journey as this sort of singular fluid product, right? Sometimes it's telemedicine, sometimes it's not, sometimes it's in person, sometimes the labs are at Quest. You need to think about two discrete products, and these are your products. They're an experience-based product. It's in person, it's what we're used to, it's what we're driving towards. But you also have to think on a different line about a commodity and convenience product. That's your telemedicine product. 100% of patients like it. It's easier for you. It's generally lower cost for the health system. You need to think about two products. So I'm going to walk you through this when it comes to food, okay? This is an easy thing. We all eat, okay? So what's an experience-based product when it comes to food? Here's your job for that product. I'm going to be hungry at some point, right? I'm going to eat a meal, and on that day for that meal, I want it to be the best possible meal, best possible outcome. My time and money, they don't matter. The experience and the outcome, right? That's what matters. I'll spend both under the assumption it doesn't make my wife mad, right? This is pretty important for me because she has to be home with the kid if I happen to leave. Great example of an experience-based product. Let's say I told you I was going to fly from Tampa to Chicago to get surgery. You'd probably say, oh, wow, yeah, that sounds fine, probably the best surgeon. I would venture that you would be okay with me traveling for a best-in-class experience, but you would think it was crazy if I got all my Lupron shots in Chicago, or if I got my labs in Chicago, right? Or even if I got them in Orlando. You'd think that was crazy, right? So what's an experience-based meal? What's this product, right? So I'd fly to Chicago. My wife would say, no problem, you can go out to dinner on Saturday. I would say, all right, I'm going to go to Alinea, right? So this experience here, this is a, this will sound crazy, this is a green apple taffy balloon filled with helium. And when you eat it, you suck the helium out of the balloon and your voice goes up like it normally would with a helium balloon. And it tastes delicious, right? So that's an experience. It's the first dessert. Here's the second one. It's like expensive space ice cream. They turn the lights off, they serve it to you while playing a song and spraying cotton candy flavored mist into the air. Then they turn on the lights and you eat it along with the balloon, right? I mean, that's madness. You wouldn't do that every day, right? But that's an experience that I would go to, right? So what are the lessons around the first product you need to develop that you've got in your site? The customer, me, is willing to burden themselves for a combo of things they can't get somewhere else. I am willing to accept burden. I'm willing to fly, money, and time to get something special. I wasn't really that worried about price. And so what we often see in our organizations is we're able to compete a little bit less on price inside of our walls. And this thing has to be memorable. So the experience that you're creating in your organization, it's got to be memorable. It's clearly got to be better than a down the street telemedicine product, right? So make sure that you're creating memories when the patients actually come to see you, but recognize there's a second product that now you have to develop that you used to be able to do 10 a week of, right? And that's the commodity or convenience product. So you got to ask yourself here, what are the problems the customer has and how can you unburden them of those problems? Never add new problems. What are their problems? How do you unburden them of those problems? So what if it's food? I'm hungry. I'm not going to cook. I'm not going in anywhere because I don't want to get all masked up and stuff. I want my wife to be happy. I don't want this to take very long, okay? This is pretty simple, my needs here. I'm not doing this in Chicago, all right? For me, 10 minutes down the street from me, $13 out of my pocket is Chick-fil-A, right? This is easy. This is a commodity. It fills my needs just the same way as an Alinea meal is, but it's a completely different product, right? You go there, it's easy. There's two lines. You say to yourself, oh my gosh, this is going to take forever, right? But the lines take about 4 minutes. Somebody courteously comes up with a mask to get your order, swipes your card, you roll on right through, and I don't even know how they make that much chicken, but it takes 5 minutes and you're eating it in your home, right? So this is a commodity-based product that is completely different than your first product at Alinea. So what does your telemedicine product need to look like, right? This is the problem statement for a lot of telemedicine visits. I'm not that sick, otherwise I would show up in your ER. I need to be sure, I need to feel comfortable that my cancer's not back, right? I need scans that are negative or labs that are stable. During COVID, I won't want to take excess risk. And before and after, my time and money are valuable commodities. Right? This sounds a lot like a commodity-based product. I'm not flying to Chicago to do a telemedicine visit. So what are the lessons for this product, right? For the commodity-based product here. First is cannot be hard. It cannot be hard. We used a previous solution for telemedicine that we actually had to shift away from because it was hard for the patient to get on. It was hard for me to figure out. And if you didn't sequence it right, it didn't work, right? That's insane when you're trying to do 1,600 of these a day or 1,600 a week. Competing on price is important. So when we first pitched, back when we were doing 10 telemedicine visits, we were saying, okay, it's going to be $50 or $100 for the visit. That's crazy, right? That's completely crazy. We ended up waiving all of the fees with telemedicine to be able to deliver care. So competing on price is going to be important. You're going to need to find that number. It doesn't have to be better than what you're doing in your site, because remember, this is a completely different product. And if you pay some homage to Clayton Christensen here, what's the job for this product, right? What's the job for the milkshake? Okay, the customer needs are very different for this product. It's a completely different ask. And if this thing is memorable or anywhere near the other products out there, you'll win the whole market. You will win the entire market. Okay, so here's somebody who won the market, right? You used to go to like the store. It used to be you needed Benadryl, right? You thought of it in the middle of the night. You said, oh gosh, I'm really itching. I need some Benadryl. You went and you got Benadryl. Now you pretty much have Benadryl at your house, right? Why is it there? It's because 3 o'clock in the morning when you woke up, you were a little itchy. You said, I'm not going to go to the store. I don't want to have an experience at the store at 3 o'clock with a mask on. I'm just going to go on Amazon and I'm going to clicky the buttons. It's going to show up tomorrow and this will be fine. I'll just deal with the itching. Right? So Amazon has essentially destroyed the in-person market by being a fabulous commodity-based market. So remember that. Think about somebody who's doing actually a couple of things well. Maybe not making ads, but I would make an argument here that Peloton's doing 2 or 3 things well. So think about their commodity-based product. You pay $2,000 for a bike. Okay, that's expensive. But once it's there, you can step out there, say, I want X time, Y person, Z music, and I want it to be a hill ride, right? Boom, it started. Your shoes are on and you're going. In 30 minutes, you're back in your house and you exercise. Saves you a ton of time driving back and forth to the gym and accepting risk. At the same time, these guys have an experience-based product. And I actually went to New York with my wife at one point, tried to get in one of these classes. They booked me a month in advance. Even if you want to get in one of the classes online, right, you're going to have to wait for it. So if I'm trying to do like, 1,000th ride somewhere, I actually have to go online and say, okay, I'm going to wait until 5 o'clock to experience this product. So these are 2 different products with the Peloton, even though it's the same physical thing. So then what are some of the keys to telemedicine? So again, I can't say this enough. It needs to be easy for the patient to use. Okay, they've got to be able to jump right on there. As Jennie said, everybody's got a computer or smartphone these days. I haven't run into a single person where that was the issue. It's got to be easy for the provider too. I've got to be able to log in simply, and then a lot of the stuff has got to sort of flow around me. So the labs or the scans, all these things have to be in my hands before I get there. I need to unburden the patient of their problems during the commodity-based visit and add no new problems. Okay, no new problems, take their problems away. And the next level thing is actually to anticipate the burdens of the customer before they exist at all, right? So think about when I do a telemedicine visit, you're nervous about your bone marrow results, your CBC, all these things, right? I've looked at them all before I get on with you. I've got them pulled up, and then I share my screen with you to show you everything and walk you through it so that you feel comfortable. I am ready for you. I'm anticipating your questions before we arrive. So one of the keys is delivering that value to the patient, taking their burdens away, and then anticipating what those would be before they know that they're even burdens. So how are you going to unburden this patient? Well, you could say, oh, you live in Miami, just come on over, right, for your labs or your scans on a Thursday. Come over tonight, we'll do them, drive back to Miami, and then tomorrow we'll go over them. Yeah, that doesn't sound very fun, right? So what you need to figure out, how are you going to be able to do labs near the patient's home, right? Can you partner with somebody? Do you have a partner? Can it be home health that you own or partner with, right? Can you leverage a large solution like a Quest or a LabCorp? What is going to unburden that patient with regard to their blood work, and how do you choose and deliver something reputable for that patient? Same thing, imaging, right? I showed imaging volumes are down. You might as well just bite the bullet on this, right? And say, how am I going to deliver value and unburden the customer? How am I going to unburden the patient of the burden of imaging, right? They need to know the imaging is good, it is near them, and then you got to think, how are they going to get me that CD, right? How are you going to get these things transmitted to me? So you've got to figure these things out. This is not the patient's problem. This is a commodity-based thing. They don't need to figure out how the Chick-fil-A line works, okay? This is for you guys to figure out. And then what happens in the visit? Important points. Provider needs to know you as a person, and they've got to have the emotional intelligence necessary to navigate the visit. These are hard to do. You don't get the human cues you get in person, right? So this is tough. Don't do them always back to back. They'll burn you out. You won't be at your best. Then what I say is make sure you're delivering excellence, excellent clinical care, encouragement, and excitement into the visit itself, right? I always want to make sure that the visit always ends with the patient on an upbeat thing, that we've always got hope about what's coming next. They're encouraged and excited about our next steps. If you're not doing those things, then you're not really delivering value to the patient and unburdening, their mind and their lives. The other thing I would tell you, please show up on time. So we talk about virtual waiting rooms. I've done telemedicine visits in in-person rooms where they think the doctor will be with you in a couple of minutes, like 40 minutes later, right? And I'm like, man, like it's like going to the doctor's office minus the drive. Like just show up on time. If it's going to be 11:30, just show up at 11:30, right? Figure it out. So summary points, okay? So to take this back down and sort of try to distill this. The first one, I agree completely. I've got 700 of these visits I'm doing every single week still. Telemedicine is here to stay, at least to some degree. If it isn't paid for, it's going to be tough to keep up. But 15% of people want this. They're the early adopters, and over time, this is going to bend the cost curve in medicine. Your organization has to do two things. They've got to change and grow if they're going to be successful. Feel free to pick one. I don't think that's a successful strategy. Remember, you're going to define better. You think you know what's right. You do not. Your patient knows kind of what's right. They define better a different way. Remember, that picture of those t-shirts. Ask somebody to do that. It's very subjective, okay? Better is a very subjective thing. And so don't assume that your outcomes will automatically result in people traveling instead of doing a telemedicine visit or something local. And then finally, and this is important, I really do think that you've got to develop two very clear product offerings. So you've got to be thinking about, all right, we're focused on the patient experience over here. My telemedicine offering, it's almost a different team of people driving a different product for a different set of patient needs. These are two different products, and you need to think of a way to deliver both of them. And I will hand it back so we can go through some questions and things.
Thank you, Dr. Kubal. That was a very interesting perspective looking at really the market value of telemedicine and how cancer centers can adjust to future demand. I also really enjoyed your analogies to other industries because I think that helps to get people thinking outside the box. So thank you for that. We are going to move into the Q&A session now. So I'll ask Dr. Crews to come back on. There she is. And we'll go ahead and get started. So our first question is regarding how both presentations advise that cancer centers keep up with the changing environment in regards to telemedicine. What do you think would happen at your centers if you attempted to get back to the status quo before COVID-19? Maybe we can start with Dr. Crews on this one.
Sure. So we were at a status quo prior to COVID-19, and we were having to really look at each project that was brought to our steering committee for its value to the patient, but also the ability for the organization to at least break even with the effort. I think that with the expansion of telehealth services in response to COVID, it would really be hard to sustain that level and scope of telehealth if reimbursement changed. I don't know that we could make a business case for that. So I think that the ability to continue doing telehealth to the degree that we have been and customizing it to the needs of the patient is really going to be dependent on maintaining some equitable reimbursement.
Okay, great.
Yeah.
Thank you so much. Go ahead, Dr. Kubal.
Yeah, I would agree. I mean, if it's not, the trouble here is if it's not reimbursed, it's going to be really tough to do. So I showed you where it really wasn't reimbursed. We were doing it for free. We were doing 10 a week. I mean, that's insane. That's zero, basically. We weren't really offering it as a product. And then here comes COVID. Patients are demanding it. They realize it's actually good. They also realize that they like coming in, especially to see a hematologist. Let's say you've got leukemia or something. It's like kind of irrelevant, right? Because I'm looking at your blood numbers to see if you're still in remission 2 years out. I don't need to press on your spleen 2 years out. So I think that if we were to switch back and say no telemedicine visits, we would lose out on that population of patients. And I would tell you that I've switched people to in-person visits from telemedicine visits under the assumption that they would want to come back, and they will actually go out of their way to switch it back to a telemedicine visit. And they won't tell me, but I'll get a bunch of emails the day of about, no, I'm not coming. We did this before. We're doing it again. It was great. So I don't think it's in the interest of the patient to go back. I don't think it's in our interest to go back either. And when you think, to be frank, about social distancing, getting 20% of people out of our physical sites is one of the only ways to get anywhere near social distancing, because I've got 40 chairs in my waiting room, or 30 chairs or 20 chairs in my waiting room. I've got 200 patients a day in the heme clinic. It just won't work unless we have 40 or 50 less there. So it will not be sustainable to go back, if I'm being honest.
Okay, and so along those same lines, let me ask you, Dr. Kubal, do you think that offering 20% of visits via telemedicine, as both of you alluded to in your presentations, is that sustainable for cancer centers if the reimbursement goes back to the rates that we saw before the pandemic?
No, that's not it. No, there's a short answer to that, is it would be no. They're going to demand some return on the physician or the provider's time, to be honest. And for me to do a full day of telemedicine visits that are limited reimbursement, that's great kind of overall from a value-based standpoint, but it's not going to deliver sort of also the value that my organization would need in this moment. So I don't think that would be doable. Jennie, what are your thoughts?
Yeah, considering that the majority of patients are Medicare patients, I think it would be a stretch. There are some states, we're one of them, that are very fortunate to have pretty liberal laws around telehealth for commercial payers, so that we do have a parity law that went into place in the state of Washington. So our commercial payers will pay us the same amount as an in-person visit. So I think some of it depends on what your payment and payer mix is, and some of it depends on what state you live in. But considering the vast majority of our patients are in a Medicare population, I think it would be tricky.
Okay, thank you. That makes sense. So another question, Dr. Crews, maybe we'll start with you on this one. How does an increase in telemedicine visits impact cancer center staffing levels? Does it change the type of staff that you utilize and that you'll need?
Yeah, it's an interesting question, because as you're trying to make the ROI for a telehealth, there is sort of temptation to say, well, we can save on staffing. And that may be true depending on how you do telehealth and what platform you use and whether or not it's integrated within your EMR completely. One of the things, as I mentioned in my presentation, that we're doing in terms of optimizing our experience with telehealth is trying to find a way to actually bring the nurses or the MAs into the telehealth visit to do the roles that they traditionally do on assessing patients, doing med reconciliation. Can't do really all the vitals, of course, but if we are successful in doing that, I don't think that it's going to necessarily change our staffing levels at all. Hopefully having that added evaluation by nursing provides value to the providers, I think, and hopefully also to the patient. So I think it depends on what model you go with, whether or not your staffing can be reduced.
Okay, Dr. Kubal, do you have anything to add to that?
Yeah, I mean, immediately, I think that's absolutely right. Right. So at our organization, there is a nursing assessment and evaluation, either via phone or video, before the visit with the MD or APP, be it a new patient or EP. Those are great evaluations. The nurse does a tremendous job of figuring out what's going on and the concerns. if you think longer term, right, the idea around having physical people on site, physical space, what you're probably going to see is a gradual shift towards less space before you have less people. And so if you're thinking about a big capital project and you're going to spend, $140 million to build a new site, for example, you might hit the pause button on that while you're looking at a 20% reduction in volumes off site before you look at having 20% fewer people there. So I would say space before people, but everything will stay the same probably for the next 6 months until we know if they're going to continue to pay for this.
Okay, great. Thank you both for that explanation. Moving on to some other questions that came in here. How do current telehealth policies reduce or worsen disparities in healthcare? Maybe we could start with Dr. Crews. Do you want to take that one first?
Sure. I think that the pre-COVID days before the emergency declaration and CMS waivers did create some significant disparities because of the way that telehealth visits were allowed to be conducted with geographic restrictions did limit certain populations of people to participate. I'm thinking about particularly urban poor. And in the rural areas, if they did meet the HSA or the MSA requirements and health provider shortage area requirements, it did help with that population. Although you can have rural areas that don't qualify, and that's a burden on those patients disproportionately. I think the other disparity that persists now that some of those geographic barriers have been lifted gets back to the access to devices, the access to internet, which are needs across the country to have more broadband availability. But in some ways, doing telehealth can help with lessening disparities for families and patients who very much depend on a paycheck. Because if they can do these visits, not coming to an office, not spending the money driving, not taking time out of work for either themselves or their family member, it really does help to provide some financial buffer for those more financially disadvantaged groups.
Okay, great. Dr. Kubal, do you have anything to add?
Yeah, I think we've got to keep an eye on this, right? I think we would both agree that we've got to keep an eye on this because there may be a population that isn't as well served by telemedicine that we discover. My thought is when I do a telemedicine visit for myself, I'm working from home, I'm wearing like a polo shirt and everything, and it's pretty easy for me to just break from my day and talk to a doctor on like a thing, right? Cool. But it's possible that if I say, worked in a retail setting or in a food service setting and I'm wearing a mask and I don't have breaks at certain times, that could be harder for me. Whereas I might say, I have to go to the doctor today. That might be more acceptable than I've got to do a telemedicine visit. So I think we really got to watch sort of that socioeconomic class difference that's showing up. And this is what we've seen throughout COVID. So I think that's something we're keeping an eye on that I imagine everyone is, but I think that's an important point to put a pin in for future discussion on telemedicine.
Right, that makes sense. Okay, thank you. Another question that just came in here, Dr. Kubal, how has language interpretation been addressed with telehealth visits? So I think they're asking about translation services for patients where English may be their second language.
Yep. So there's 3 ways to do this. Way number 1 is not to do it. That's not really an option, right? I don't think that's fair. I don't think that's reasonable. So what we've adopted is one of the other 2 options depending on what you're doing. So one of them is that the link for the telemedicine visit is shared with one of our on-site interpreters. They're also working from home, and so they will get onto the Zoom visit, which will be shared. You can also do and this is awesome, you can actually do a multidisciplinary cancer care visit by getting like a surgeon, an oncologist, and a rad onc on the phone at the same time with an interpreter. So you can actually do more cool things from an interpretation standpoint like that. if you don't have access to on-site interpreters, for example, you could leverage some of the phone-based systems, and we've done that as well to call in and have that all flowing that way. So I think not doing it's not an option. I actually love pulling the interpreter in for that face-to-face. So are you guys doing the same thing, Jennie?
Yeah, we, there are some systems where the EHR, if you're doing telehealth through that, you can have the on-demand access to interpreter services. We're not in that state right now. So we've kind of gone old school with being able to pull in our interpreter service like you're describing.
Yeah, it's actually really awesome. I mean, it's face-to-face. They're watching what the patient is doing, and especially if you're doing that multi-D visit, I mean, it's actually quite cool.
Yeah.
Great, thank you. So here's another one that just came in from the audience. Do you include home infusion as part of telehealth service you provide?
We are not.
That one.
Yeah, we're not doing that. I think that's a great future state to plan for. I know that home infusions are being looked at. They're being performed by some agencies, but we're not incorporating that as part of telehealth at this time.
Yeah, so we haven't yet either, and this is probably a great subject for a future webinar, but here's what I'll tell you. There's been some great press around, I think, Penn being able to deliver, half a dozen or a dozen drugs in the home, things like Lupron, the injectables. We have done some work at Moffitt where we had our pharmacists look at all of our chemotherapy agents, and what they essentially said they said, Tim, 50% of those drugs could be delivered in the home safely. Now, the scale of needing to do that, the number of nurses, the stability of the drugs, monitoring for issues, none of that's worked out. But is it possible to do? Absolutely, right? It's already being done for injections. I think that's the next model would be, is there something cohesive that is, it unburdens the patient. It unburdens the patient. Can you come to my house and give me 7 consecutive Vidasa injections? Absolutely, right? That's easily done. So that's something that needs to be talked about. It needs to be what comes after the telemedicine being reimbursed. Because we all know, Jennie, that like as soon as I send that into the home, the issue is I also lose reimbursement for the chemotherapy. And that's a completely separate problem where I can't keep my doors open if I stop doing medications.
Yeah.
Great, thanks, Tim. And you actually gave me a great leadway to mention that our next webinar, we will have a physician from Penn talking about the home infusion that they increased, and that's on Tuesday. So thank you for that. That is coming up next. Another question that came in from the audience, and maybe we'll start with Dr. Crews on this one. As more imaging tests are done off-site, how does one validate the quality of such imaging at these other places?
That's a great question. I think that's a challenge now for a lot of academic centers when a patient shows up here with films from somewhere else, they get repeated, right? So we have a lot of opportunity to take out some waste of the system there. I don't know what sort of standardized quality metrics are in place for validating imaging from other sites, but I think both that and lab quality do play into telehealth a lot, because in an ideal world, as Tim was describing, patients would be at home getting those things locally. They'd be sent via electronic means to you as a provider to review, and then a telehealth visit could be conducted. So I do think that's a problem we have to solve for.
Okay, thank you. Dr. Kubal, do you have anything to add?
Yeah, I think there are things that you can do in the community now. CBC with diff, CMP, awesome. Get that near your house. Flow for T-cell panel, I don't know, probably not, right? PCR for minimal residual disease, there are going to be things that feel like they need to be done with me, but over time, I think that the market will be able to do those better out in the community. For imaging, CT tap. 3 years out from diffuse large B-cell lymphoma or something like that, right? Sure, that's probably fine. You're asymptomatic, but trying to discern in somebody who's on a clinical trial, right? Is their tumor getting bigger or smaller? Two different people looking at that scan, two different sites doing that. I might change therapy based on a scan that's not, super duper high quality. And so you really got to, again, you don't want to burden the patient with that second scan, that second bone marrow, that second set of labs. And so if you're going to burden them with going somewhere near their house, make sure that it's not going to double the burden when you repeat it.
Mm-hmm. All right. Okay, thank you. So moving on to another question here. Do you believe that reimbursement for telemedicine visits should be the same level as in-person visits going forward? So should they be reimbursed equally? Is the same value being provided? What do you think about that one, Dr. Kubal?
I have waffled on this concept here. I think that what I'm delivering, the value I'm delivering, and how I'm again unburdening that patient, I think that is paid the same way in person or via video. But I also recognize that the cost of medicine has been driven by my cost structure, right? So I have a huge building, I heat and cool it, therefore the visits must cost X, right? Cost divided by Y. So I do think over time, we're likely to see some erosion of that payment for the visit, even if I think that it should be paid for at the same number. So we would need to be prepared if there were to be some erosion of that number, just because people would say, well, you're not having to pay for all those facilities. You're still getting what you want, and I think it should be paid the same. These visits are harder for me to do. They're more difficult, right? It's challenging to do as opposed to in person. So I think it should be paid the same, but I'm also cognizant that you might see some backsliding on that.
Thank you. Dr. Crews?
Yeah, as someone who's just participated in our state battle to get payment parity for telehealth visits, I have to say I do feel pretty strongly that the professional component of these visits should be the same. I think, a lot of the decision making that goes into seeing a patient is equally done by telehealth or virtually as it is in person, and that's where a lot of the value, I think, of that patient's visit occurs, not so much necessarily in the physical exam. So out of the components of care that are comparable, I do think that there's enough equity that the payment should be equal as well. And that's really for the professional component. I agree that the facility fee piece we should really think about, because facility fees are indeed meant to capture all of those other wraparound expenses of a patient coming in your door, and all those other services that you offer. So if you're not offering all of those services, if there's some sort of pay scale that they could be captured on. But for the professional component, I feel pretty strongly that, yeah, it should be equal.
Great. So let me ask you this. Do you think, and this is going back to our previous question about, is it sustainable for cancer centers to have 20% of their visits remote? If the professional fee is equal to an in-person visit, but the facility fee is either non-existent or lower because it's telemedicine, would that possibly be sustainable for cancer centers to continue providing telemedicine in the future?
Tim, do you want to start that one?
Oh, man. Well, I'll tell you, here's what I'll say. Our organization has actually done this. We've done a deep dive on what happens if the facility fee goes away. I would hope everybody had done that analysis, and if they had, they know what it looks like. It doesn't look great. But we've also prepared for that eventuality, so we know the changes we would have to make to adjust for that if it were to go away. So, I mean, I think if it were to go away net total, we'd be in a bit of trouble. But however, if there were to be a reduction that was sustained in the facility fee, for example, it's 8 to 20 or 30% of what it was, I think we can survive on that. But remember, we'd have to change our cost structure and also grow to a larger number of these visits. So we'd have to sort of leverage our fixed assets, so to speak, in a better way.
Right, okay.
Survivable?
No, it's, I was just going to say that it is our addiction on fee-for-service. I think those of us who are further into the value-based world can probably do better at converting over to telehealth and weaning themselves from the facility fee dependency. I think we all need to do that eventually, or find out what our margin is that we could accept in loss of facility fees in order to figure out what the right mix of in-person telehealth visits is from a financial standpoint, not from a patient care standpoint.
Right. Okay. So it sounds like a lot for cancer centers to consider. Telemedicine visits are here to stay. We're going to need to provide them. Patients really like them. We just need to figure out a sustainable way for the reimbursement to work, and also all the policies surrounding that. So with that, let me ask one final question here, and maybe Dr. Crews, we can start with you on this one, this last question. Do you think the expansion of telemedicine could have a role in decreasing healthcare costs in the United States?
Yeah, I do. I think there's already some great examples and published data on keeping patients out of the ED and out of the hospital using telehealth and other digital health means. So clearly there's a case to be made there. I also think that it does provide another tool in the toolbox for people who are in a value-based world, and another way to reduce overall healthcare costs for those folks.
Mm-hmm. Great. Okay, thank you. Dr. Kubal?
No question, 100%. I mean, if you've ever seen that patient that calls 22 times in like a half day because they can't connect with somebody, then they go to an emergency room, and then they go to another emergency room, and then they get transferred to your hospital the next day, and they have something that you could have dealt with on the phone, right? The doctor that knows them says, oh, this happens all the time, and they could get me in the matter of an hour or two. You're skipping all those costs. You're skipping all that time and money costs for those things. You're skipping the stress for the patient, and then they're not burdened with that decision to go to the ER, the bills associated with that, the workup that's unnecessary. If it tethers us more tightly to the people that know them, it will always decrease the cost.
Great, thank you. I think those are all very excellent points for all stakeholders in our healthcare industry to really think about as we move forward, providing the telemedicine in the future. So with that, I think that is all the time that we have today. If there are any questions that we did not get to, we will try to respond via email, or please feel free to reach out to us directly. And we would like to say a very special thanks again to our supporters for making this program possible, and to our speakers today for sharing your expertise. So thank you so much, Dr. Kubal and Dr. Crews. I did want to mention very quickly here that the next webinar in this series will be on Tuesday, June 23rd, starting at 2 p.m. Eastern, and it will focus on modifications in cancer treatment and delivery due to COVID-19. So we do hope you are all able to join us for that. Thanks again, and we will see you next time.